Hi guys, I hope I'm audible to all of you. I'm just confirming from the Hari and team whether the video is clear and the audio is clear. So once he gives me a confirmation, we will go ahead with the discussion today. Hmm. Okay, so today we will be spending 4 or 5 hours, and in that 4 or 5 hours, we will be reasonably able to revise all the major systems and the key points that you need to remember for the exam. Now, it's not the time for you to get into a conceptual understanding. If there is something which you have not understood, it's better that you leave it, but try to remember it instead of trying to go behind understanding it. But whatever you have understood, retain it, revise it, reproduce it. Okay, so we'll start with the neuro first. And in the neuro, what kind of questions are asked? In the neuro, the basic questions are differentiating between UMN and LMN lesion. Second is localization of lesions. Third, myasthenia gravis, GB syndrome, stroke management related questions, and then some rare diseases like the amyotrophic lateral sclerosis, multiple sclerosis. These are the important topics. So let's get going. The first thing we need to address is UMN versus LMN. We know that when it comes to motor system, we have an upper motor neuron that begins where the upper motor neuron begins in the brain, the motor area. Where is the motor area located? Motor area is located in the frontal lobe, anterior to the central sulcus, right? So from there, the axon descends down to form what we call as pyramidal tract, and it continues to descend through the spinal cord. Each neuron that originates in the motor area of the brain has a destination spinal segment. So till the destination spinal segment is reached, the neurons continue to descend. Once the destination spinal segment is reached, the neurons leave the pyramidal tract, go into the gray matter and synapse with the next order neuron. So this neuron is what we are going to call it as upper motor neuron. For those who are totally blank, let me give you a pictorial representation. So we know that we have a motor area. If I have to see a side view, the motor area is present anterior to the central sulcus. Brodmann area number 4, and this is our motor area. The cell bodies here are the cell bodies of the upper motor neuron. So if I take a cross section through this and split the brain side by side, then this is going to be my motor area. And as you know, in the brain, periphery is where we have the gray matter, and that is where you have the cell bodies of all the motor neurons, the cell bodies of all motor neurons. These cell bodies, we call them as Betz cells. What are these cell bodies called as? These are cell bodies of upper motor neuron, and we call them as Betz cells. These are called as Betz cells. These Betz cells send their axons down to form a tract. That tract is what we call as the pyramidal tract. Pyramidal tract. And you already know that this area is where the lower limb is represented, and this area is where the upper limb is represented. And this is the area where the face is represented, or head and neck region is represented. And you know that the face is controlled through cortico bulbar tract, limbs or the rest of the body is controlled through pyramidal tract. So it forms this tract called as pyramidal tract. Now this pyramidal tract, the first MCQ they will ask is where does it decussate, and you all of you know that it decussates at the lower end of the medulla. So it descends down till it reaches the lower end of the medulla and decussates at the lower end of the medulla and enters the spinal cord as the pyramidal tract. And in the spinal cord, because it is laterally positioned, we will call it as lateral corticospinal tract. Pyramidal tract in the spinal cord is positioned laterally, so we call it as lateral corticospinal tract. So this is my brainstem, midbrain, pons, and the medulla, and the lower end of the medulla where the decussation happens. So that is again an important MCQ. The pyramidal decussation site. Pyramidal decussation occurs at the lower end of medulla. This is a potential MCQ. Now this tract contains what? This tract primarily contains the upper motor neurons. Upper motor neurons. And these upper motor neurons, once they enter the spinal cord and once their destination spinal segment is reached, they come out of the tract and form a synapse with the lower motor neuron. And lower motor neuron comes out from the spinal cord as a motor nerve and supplies the destination muscle. So as we know now, the tract contains what? Tract contains upper motor neuron, and the peripheral nerves contain lower motor neuron. In terms of functions, combined upper motor neuron and lower motor neuron combined are responsible for the contraction of this muscle. Signal is initiated by the upper motor neuron. The exact site of initiation of the signal is the axon hillock. You know that there is a cell body and a axon, and there is a axon hillock. That is where the signal starts. And once the signal starts, it travels all the way down through the upper motor neuron, and then the signal is handed over to the lower motor neuron. And once the lower motor neuron picks it, the signal is handed over to the neuromuscular junction. That is where we release the acetylcholine, and acetylcholine causes the contraction of the muscle. So that is one function. So whenever upper or lower motor neuron is damaged, the muscle will not be able to contract. We will have the weakness. Apart from that, this lower motor neuron is responsible for constantly firing signals to make this muscle partially contracted, which we call as tone. So LMN is responsible for muscle tone, and UMN plays a role of suppressing the muscle tone. Similarly, LMN is part of the spinal reflex arc. So whenever we elicit a deep tendon reflex, the signal goes to the spinal cord through the sensory neuron and comes out for the contraction of the muscle through this lower motor neuron. So LMN is responsible for maintaining muscle tone as well as reflexes. And UMN plays the role of suppressing both the tone and reflexes. So that's why whenever there is a UMN or LMN lesion, weakness will be there for sure. But apart from that, LMN lesion will have loss or decrease in muscle tone. So when it comes to the tone, if I look at the tone, in UMN lesion, it will be decreased. So we will be having hypotonia. And as you know, hypotonia is also called as flaccidity. It is also called as flaccidity. But UMN lesion, suppressing role taken away, the tone increases. We will call it as hypertonia. And I've already discussed about this. Hypertonia is of two types. What are those two types? Rigidity and spasticity. UMN lesion produces what we call as spasticity. Now, what is spasticity? Spasticity refers to a form of hypertonia where the resistance is not same throughout the range of movement. It is initially high, and as you continue to stretch, the resistance decreases. In case of rigidity, the resistance is same throughout the range of movement. So here what we are getting is spasticity. And you should also know that spasticity is also called as clasp knife rigidity. It is also called as clasp knife rigidity. Okay. Then with respect to the deep tendon reflexes, for the reflexes, LMN is responsible. If it is damaged, the reflexes will diminish or go absent. So you can have hypo or areflexia when there is damage to LMN. On the other hand, UMN damage, suppressing role, suppression taken away, reflexes become increased. So you will have hyperreflexia. And another point, probably I don't remember talking about it to you in the offline class, an exaggerated form of hyperreflexia, severe hyperreflexia, where you hit the tendon once and instead of getting one brisk contraction, you get multiple contraction. What do we call that as? We will call it as clonus, right? So in addition to hyperreflexia, you can have clonus. What is this clonus? Sustained or repeated contractions to a single stimulus. So when you're doing a knee reflex, you hit once. What do you expect? The knee extension once. But if it keeps extending again and again, we will call it as clonus. So clonus is a form of severe hyperreflexia. One stimulus giving multiple contractions. Okay, so that is what you can see in UMN lesion. The third one is about the plantar reflex. The plantar reflex, by default, we are born with an extensor response, which we call as Babinski sign. But as we start aging, we start losing that extensor response and we gain the flexor response, where the great toe goes into flexion, other toes get crowded. That's the adult normal response. Newborn response is opposite of it. Great toe goes into extension, other toes go into fanning out. That's the newborn's response. The switch is usually due to UMN. So when UMN is damaged, you will have a plantar reflex which becomes same as what you are born with, because UMN was switching extensor to flexor. UMN is gone, you're back to extensor. So you can have an extensor response, which is called as Babinski sign. Babinski sign positive, or positive Babinski sign. But in UMN lesion, you can have a flexor response or an absent response. Absent response is also called as mute response, right? It's also called as mute response. Now the last bit, I think most of you probably know this. They might ask you, in what circumstance you will get atrophy and fasciculations. So now we understand that when we talk about LMN, everything is going down. Means what? The tone is down, reflexes are down, and the plantar response is also going down, flexor. When UMN is damaged, everything goes up. Means your tone is increased, hypertonia or spasticity, deep tendon reflexes are exaggerated, and the plantar response is extensor, right? Okay. Now you should also know that the muscle bulk depends on the work done by the muscle. And in case of UMN lesion, the voluntary work that a muscle used to do, because weakness is there, it is gone. Voluntarily, patient is not able to do any work. But there is another work which is tone. Tone is nothing but partial state of contraction of a muscle when it is not actually doing any work, and that is increased. So all the muscles are more contracted when they are not doing any work. That prevents development of atrophy. But in case of LMN lesion, that work is also gone because there is hypotonia. So you get this classical atrophy and fasciculations. So atrophy and fasciculations are considered as hallmarks of they are considered as hallmarks of LMN lesion. They are considered as hallmarks of LMN lesion. Okay, clear? So now this is a table that I definitely want you to remember. One question is expected from this for sure. So that's the first topic of importance for us. LMN versus UMN lesion. Okay. After this, the next topic that we're going to address is localization of lesions. That is primarily important for us to understand about which disease a particular question is talking about. I've done the detailed discussion in the offline class, so I will only reiterate the key points. So second topic we're addressing is localization of lesions. And when it comes to localization of lesions, the lesions can be localized from the muscle, neuromuscular junction. So in this whole hierarchy, we have different sites of localization. A disease may be affecting muscles like Duchenne muscular dystrophy or endocrine myopathies, or a disease may be affecting neuromuscular junction like myasthenia gravis and Lambert-Eaton syndrome. A disease may be affecting the peripheral nerves like GB syndrome, diabetic neuropathy, vitamin B12 deficiency, then leprosy, lead neuropathy, then all these compressive causes, median, ulnar nerve palsy. These are all diseases of peripheral nerve. A disease may be affecting spinal cord, and when it is affecting sectional, a disease may be affecting brainstem, subcortex, or cortex, right? So today we will just make a list of how do I identify whether a particular disease is talking about muscle disorder or a question is talking about neuromuscular junction disorder. So what are those key points? So we'll begin by first addressing the muscle. So when it comes to muscle disorders, we have made a long list of examples. I will only write down the important examples now. The endocrine myopathies are the most common cause, as you know, when it comes to muscle disorders. Endocrine myopathies are the most common cause. And among endocrine myopathies, the important ones that you need to remember is diabetes mellitus, hypothyroidism, because these are pretty common. Hypothyroidism, hyperthyroidism, then acromegaly, Apart from that, another important example for muscle disorder is autoimmune. And when it comes to autoimmune, the disease that should come to your mind is dermatomyositis. Dermatomyositis is an autoimmune muscle disorder. And then you should also remember some drugs. And when it comes to drugs, statins is what I want you to remember without fail. Statin induced myopathy is very, very common, affects 5 to 10% of the people who are taking statins. Okay. And then inherited. And when it comes to inherited, the important ones that I want you to remember, you're all familiar from pediatrics, that is Duchenne muscular dystrophy and Becker's muscular dystrophy. Both of them due to mutation in a gene called as dystrophin. Becker's is relatively milder disease. Patients are likely to survive into adulthood. Duchenne muscular dystrophy is more aggressive. Most patients don't cross the teenage, they die before that because of the involvement of heart. They develop cardiomyopathy and die because of that, or maybe because of the respiratory muscle involvement. Now, in terms of weakness, what is the pattern of weakness in a patient with muscle disorder? When it comes to muscle and neuromuscular junction, generally larger muscles get affected first. So that's why they present with what we call as proximal muscle weakness. So these patients will have difficulty to lift objects, difficulty to comb, difficulty to raise the shoulder above the level of head, difficulty to climb stairs, and difficulty to get up from sitting position. And that difficulty to get up from sitting position, when seen in patients with Duchenne muscular dystrophy, we call it as Gower's sign, right? That is classical presentation of muscle disorders. The next site we have in the localization is going to be the neuromuscular junction disorders. Neuromuscular junction disorders. We know that there are two neuromuscular junction disorders. The first one is myasthenia gravis. That's the most common neuromuscular junction disorder. And the second one is Lambert-Eaton. Lambert-Eaton syndrome. These are two neuromuscular junction disorders. These patients also, when they present with weakness very similar to the muscle disorders, that is proximal weakness, but there are some additional features. What are those additional features? These patients' weakness includes facial muscles as well. Ptosis is the earliest symptom of myasthenia gravis, as you remember. So they will have facial plus proximal weakness, and along with that, these patients often have diurnal variation. Means the weakness is not constant throughout the day. It keeps either increasing or decreasing. For example, in myasthenia gravis, as the day progresses, the weakness goes on increasing. And in case of Lambert-Eaton syndrome, as the day progresses, the weakness goes on decreasing. It is not going to be static. Muscle disorders, it is same. Morning, afternoon, evening, it is same. Stroke, morning, afternoon, evening, it is same. Cut the spinal cord, morning, afternoon, evening, it is same. It does not show variation within a day. So this diurnal variation is what we call as the hallmark of neuromuscular junction disorders, because we don't see that in any other condition. This is called as hallmark of neuromuscular junction disorders. Hallmark of NMJ disorders. Okay, so that's about the neuromuscular junction disorders. After neuromuscular junction disorders, next we have in the hierarchy is the peripheral nerve disorders. And remember, when we talk about peripheral nerve disorders, we classify them based on the number of nerves affected. If only a single nerve is affected, we will call it as mononeuropathy. We will call it as mononeuropathy. When all the nerves are diffusely affected, we call it as polyneuropathy. But multiple single nerves discretely affected, not diffusely affected, we will call it as mononeuritis multiplex. Mononeuritis multiplex. Example for mononeuropathy are usually compressive neuropathies. When something, radial nerve or ulnar nerve or medial nerve gets compressed, that nerve will get damaged and only the muscle supplied by that nerve will be affected. Compressive neuropathy is a classical example for mononeuropathies like ulnar nerve palsy. Mononeuritis multiplex, I want you to remember only one example, which is leprosy. Leprosy is where multiple nerves get affected, not diffusely all, not single, multiple nerves get affected. And leprosy is primarily a neurological disorder with skin as a like another organ affected. But the main problem with leprosy is it's a neurological disease. That's why for diagnosis, we use either ulnar or sural nerve biopsy. Okay. Polyneuropathy, we can quote the examples as acute and chronic. Polyneuropathy, we have acute and chronic. And when it comes to acute, we have only one example to remember. What is that example? The example for acute is GB syndrome. The example for acute polyneuropathy is GB syndrome. Chronic के लिए we have multiple examples. Diabetic neuropathy is the most common cause for polyneuropathy. Diabetic neuropathy is the most common cause for polyneuropathy. Almost every doctor will see one or the other diabetic neuropathy case for sure. Then another example we can quote is B12 deficiency. Then lead toxicity, which is also called as plumbism. We can also call it as lead neuropathy. So these are all common causes for polyneuropathy. Now these we don't have to discuss because they present with the symptoms related to those particular nerves. So you know from anatomy what muscles ulnar nerve supply. So if there is ulnar nerve palsy, you will present with the weakness of the muscle supplied by ulnar nerve. If there is radial nerve palsy, you present with weakness of muscle supplied by the radial nerve. In leprosy, depending on what all nerves are affected, those muscles will become weak. But polyneuropathy has a classical presentation. What is the classical presentation of polyneuropathy? Weakness in polyneuropathy conditions. So when it comes to muscle and neuromuscular junction, the larger muscles tend to get affected first. When it comes to the neuropathies, polyneuropathies, the longer nerves get affected first, and longer nerves are the ones which are supplying the distal parts of the body. So that's why you will have weakness which is affecting distal. So you will have distal muscle weakness. And what symptoms a patient with distal muscle weakness is expected to present with? Small muscles of the hand, we use it for grip. So patients often complain of dropping objects, which we call it as clumsiness, right? Or grip weakness. Lower limb, they will have difficulty to cling onto the slipper. So they will present with slipping of slippers. Then forearm also comes under the distal muscles. They get affected. So patient may develop wrist drop. In the lower limb, they may develop foot drop, right? So distal muscle weakness presents with grip weakness. So these are all buzzwords. Now you should remember if these words appear in the exam, that means the examiner is giving you clue that this patient is having distal muscle weakness. So if it is talking about grip weakness or clumsiness or dropping objects. Okay, those who want to follow the notes, these notes for the revision, don't worry, I will share it with Hari. He will put it in the group and you can definitely use it. Dropping objects, wrist drop, slipping of slippers, and foot drop. These are the usual symptoms of polyneuropathies, right? Distal muscles are the ones which are getting affected first. So they present with classical distal weakness. On the other hand, the neuromuscular junction disorders had proximal weakness. Muscle disorders also had proximal weakness. Neuromuscular, in addition to that, they have facial involvement and the diurnal variation. In the peripheral neuropathies, because peripheral nerves also contain sensory neurons, we will not only have the weakness, we will also have loss of sensations. So they will also have loss of sensations, and these loss of sensations will also be affecting distal body parts. And because sensation loss and muscle weakness is both distal, We also call this manifestation as what? The glove and stocking distribution. Glove and stocking distribution. That is where we wear the gloves and stockings. So anyone has distal weakness, distal loss of sensation is a case of polyneuropathy. Anyone who has proximal weakness, no face, no diurnal variation has muscle disorder. Anyone who has proximal weakness but also facial involvement and diurnal variation has neuromuscular junction disorder. So after the neuromuscular junction, we go to the peripheral nerves, and after that we go to the spinal cord. And when we discuss spinal cord, we have learned that spinal cord can be cut, hemisection, transection. Spinal cord can be compressed from outside to inside or from inside to outside. And there can be non-compressive myelopathies. So the next site of localization is spinal cord. And when it comes to the spinal cord, we will have first sectional disorders. And when we talk about sectional disorders, we have complete transection and hemisection. How a patient with complete transection present? Remember, the tracts are crossing somewhere. All the tracts have to cross because right brain has to control left side of the body, left brain has to control right side of the body. Majority of the tracts are crossing at the lower end of the medulla except one, which is crossing at the spinal cord itself. That is your pain and temperature tract, which is called as lateral spinothalamic tract. The dorsal column, which is carrying fine touch, vibration and proprioception, and the pyramidal tract, which is concerned with motor movement, is crossing at the lower end of the medulla. Only tract that is crossing at the spinal cord is the lateral spinothalamic tract, which is concerned with pain and temperature, right? This is one important anatomy point you need to remember. Okay. So when I cut completely, it doesn't matter where any tract is crossing. If you cut completely, there's no connection between the portion above the cut and portion below the cut. So whether I cut at cervical or thoracic, the brain will not be able to communicate below the cut. Any information below the cut will not be able to go to the brain. So when we do transection, patient present with first horizontal level of weakness. Horizontal level of weakness. And that horizontal level of weakness could either be quadriplegia or paraplegia. When do you get quadriplegia? When the level of lesion is in the cervical segments, because the upper limb receives the nerve supply from brachial plexus, which is formed mainly from the cervical segment C5, C6, C7, C8 and little bit from T1. So if the lesion is in cervical segments, then you end up with quadriplegia. But if the lesion is in below cervical segment, means thoracic or lumbar, because the lumbosacral plexuses are responsible for giving the nerve supply to lower limb. So if the lesion is below cervical segments, you end up with a person developing paraplegia. Clear horizontal, right? Cut here, upper limb, lower limb, all gone weak. We will call it as quadriplegia. Cut thoracic level or lumbar level, only lower limb becomes weak. We will call it as paraplegia. So along with that, these patients will also have horizontal sensory loss. Horizontal sensory loss. If I cut at the T4 segment of the spinal cord, below nipple, because T4 is through nipple is regulated through T4. So below nipple, all the sensation will be lost. Above nipple, all the sensations will be preserved. So this patient will have a horizontal sensory loss. And the third manifestation that we can expect apart from motor and sensory losses, they will lose control on the bowel and bladder, because bowel and bladder, though regulated by autonomic nervous system, their external sphincters are under the control of voluntary control, and those nerves will be damaged. So we'll have bowel and bladder incontinence. Bladder incontinence. So these are the manifestations we are expecting whenever we have transection of the spinal cord, right? What we call it as horizontal level of weakness, quadriplegia or paraplegia. Along with that, same sensory loss and bowel and bladder dysfunction. But when we cause hemisection, only one half of it is cut, not both the sides cut. The hemisection is also known as Brown-Sequard syndrome. It's also called as Brown-Sequard syndrome. So what happens when you develop Brown-Sequard syndrome? You're cutting half of the spinal cord, and you know that two tracts are going on the same side. They will decussate to the opposite side at the lower end of the medulla, and one is already crossing in the spinal cord itself. So that results in a differential uh, presentation. So ipsilateral side, you will have ipsilateral loss of motor strength, or you can say weakness. You will have ipsilateral loss of motor strength, or you will develop ipsilateral weakness. And also you will have ipsilateral loss of dorsal column sensations. So what are the dorsal column sensations? The dorsal column sensations are fine touch, vibration, and proprioception. So those will be lost on the same side of the lesion. But you will have, remember, I have told you in the offline classes that pain and temperature. Think about pain always to the opposite, right? And some of you might remember I had quoted the Deepika and Ranveer story. So you will have contralateral loss of pain and temperature sensations. And these are carried through which tract? These are carried through lateral spinothalamic tract. Lateral spinothalamic tract. So these sensations will be lost on the contralateral. The only thing you need to remember is pain always opposite when it comes to hemisection. Okay, so that's about the cut of the spinal cord. After the cut, we also have what we call as compression, right? So let us also talk about the compressive myelopathies, what we call as compressive myelopathies. What do you mean by compressive myelopathies? You're not cutting the spinal cord, but you're compressing them from either outside to inside or from inside to outside. So we'll call them as compressive myelopathies. And just for a quick revision, remember the cross-sectional anatomy of the spinal cord. So when you look at the cross-sectional anatomy of the spinal cord, the first thing you should remember is that we have the gray matter, which is positioned like a butterfly, and that butterfly arrangement gives rise to what we call as an anterior horn and a posterior horn. Anterior horn is where the motor neurons are there, and posterior horn is where the sensory neurons are there. Anterior horn is where motor neurons are there. Okay. Now we have two major tracts. Here one we call it as pyramidal tract, another lateral spinothalamic tract, and posteriorly we have dorsal column. Okay, so let me call this as lateral spinothalamic tract, which is concerned with pain and temperature, and this as the lateral corticospinal tract, which is nothing but pyramidal tract, which is decussated at the lower end of the medulla. And the arrangement of neurons in these tracts is the cervical neurons are the most medial, followed by thoracic, followed by lumbar, and then sacral. And the same arrangement we find in the sensory tract as well. So cervical is the most medial, followed by thoracic, lumbar, and sacral. Cervical, thoracic, lumbar, and sacral. The easiest way to remember this is C towards the center, S sidewards. Now, whenever a tumor originates inside and tries to compress these structures, first thing that gets compressed is the cervical neurons, right? If there is, let us say there is a tumor, it is expanding, first it will compress cervical. So cervical segments are responsible for nerve supply to the upper limb and sensory information from the upper limb. So I will lose upper limb strength and upper limb sensation. As it progresses further, I will have loss of thoracic and abdominal muscle strength, Eventually, when it reaches the lumbar and sacral, I will have loss of lower limb strength. So this is classical descending paralysis. But if a tumor comes from outside, first it hits the sacral and then lumbar. So my lower limb will become weak first and I will lose sensations in the lower limb first. And then eventually when the tumor becomes large enough to reach the cervical segments, upper limb becomes weak. So this is classical ascending paralysis. So when we compress, we will have two types of compressive myelopathies, as I just discussed. The compressive myelopathies coming from outside, we will call it as extramedullary, and coming from inside, we will call it as intramedullary. If a tumor comes from inside, remember C4 center, cervical segments are the most medially positioned, so tumor first compresses the cervical. And if it comes from outside, sacral segments are the most outside located sacral neurons, so they get compressed first, so we'll have ascending paralysis. So intramedullary presents with descending paralysis. Extramedullary presents with ascending paralysis. Intramedullary will have descending sensory loss, and we can count this as sacral sparing because tumor is coming from inside. The last neurons to get affected are sacral, so it can be sacral sparing. So this is also called as sacral sparing sensory loss, is seen in which this is an important MCQ. Okay, and on the other hand, in patients with extramedullary, we get ascending sensory loss, and the sacral is the first affected. Ascending sensory loss, and because tumor is coming from outside, sacral neurons are most sidewards positioned, so sacral region is the first affected region. Okay, so that helps you to differentiate between intramedullary versus extramedullary. Another important point that we had discussed in the classes is that CSF abnormalities. Because we draw the CSF from the subarachnoid space, which is situated here, a tumor coming from outside is more likely to disturb this space than a tumor coming from inside. So that is why CSF abnormalities are more common in extramedullary spinal cord compression. So CSF abnormalities are more common in extramedullary compression. CSF abnormalities are usually present here. CSF abnormalities are rare in patients with intramedullary compression. These are rare. So these points will help you to differentiate between intramedullary and extramedullary spinal cord compression. So spinal cord, what we have learned, you can cut it completely, you call it as transection, that produces quadriplegia or paraplegia depending on the level of cut. Hemisection produces classical same side weakness, same side loss of dorsal column sensation, but opposite side loss of pain and temperature. If you compress from outside inwards, you will get ascending paralysis, ascending sensory loss, sacral is the first affected, you can have CSF abnormalities. You compress from inside to outside, cervical is the first affected, so you have upper limb weakness first, so you will have descending paralysis, descending sensory loss, and sacral sensory loss will be the last, so we also call it as sacral sparing, and CSF abnormalities are less likely. So from there we ascend up to brainstem, and when we do any damage to brainstem, in the brainstem we have the cranial nerve nuclei from where the cranial nerves originate, but cranial nerves do not cross to the opposite side. Cranial nerves UMNs would have already crossed. Some of you had a lot of difficulty understanding this, so I will just reiterate one more time that when it comes to the body control and the head and neck control, for body control we have pyramidal tract, for head and neck control we have the corticobulbar tract. So for body control, the pyramidal tract originates in the motor area and it decussate at the lower end of the medulla and then enters the spinal cord. And for the, let us say these two are representing the motor control of the body. They are crossing at the lower end of the medulla, right? So this tract is what I call as pyramidal tract. This is for the control of limbs, upper limb, lower limb regulation. And then for the head and neck, we have corticobulbar tract and cranial nerves. So they begin their journey in that face area. Remember, here we have the lower limb, here we have the upper limb represented, and here we have the face. So from the face area or the head and neck region, it begins and it crosses to the opposite side above the brainstem. This tract crosses to the opposite side above the brainstem, and then in the brainstem it joins its nuclei, which we call as the cranial nerve nuclei, and from there we will have the origin of the lower motor neurons of the cranial nerves. Okay, so now whenever we cause the damage to the brainstem, if I'm causing damage here, I'm causing the damage to the UMN of the limb going to the opposite side, but I'm causing the damage to the LMN of the cranial nerve on the same side. So if there is damage here, I will have ipsilateral cranial nerve palsy but contralateral hemiplegia. Anytime I do damage above the brainstem, like if I do damage here, then I have damaged the upper motor neuron going to the limb for the opposite side, and also the upper motor neuron of the cranial nerve going to the opposite side. So I will have cranial nerve palsy as well as body weakness on the contralateral side when the lesion is above brainstem. But when it is at brainstem, the cranial nerve is on the same side but body is on the opposite side, which we call as crossed hemiplegia, right? We call that as crossed hemiplegia. So when there is lesion at brainstem lesion produces classical crossed hemiplegia, produces what we call as crossed hemiplegia. And what do you mean by that? Crossed hemiplegia refers to ipsilateral cranial nerve palsy. Cranial nerve palsy is on the same side, that too element type, because the nucleus is affected. Plus you will have contralateral hemiplegia and hemisensory loss. This we call it as crossed hemiplegia, right? We are going to call it as crossed hemiplegia. It's a hallmark of the cranial nerve palsy. And I think I've also told you that you can localize precisely which part of the brainstem is affected in brainstem lesion, because you know that cranial nerves 3 and 4 have their nuclei in the midbrain, and then 5, 6, 7 and 8 have their nuclei in the pons, and then 9, 10, 11, 12 have their nuclei in the medulla. So if any question is talking about, let us say, right third nerve palsy and left hemiplegia, it is classical crossed. Third nerve palsy is on the right, hemiplegia is on the left. Left hemiplegia, right third nerve palsy, it is crossed. Now, the moment I know that right third nerve palsy, we know the side of lesion. The lesion affects on the side of cranial palsy. So if the cranial nerve is affected on the right side, then the lesion is on the right side, because ipsilateral to sirf cranial nerve ka hota. And the number third affected, that means the problem is in the midbrain. The same question, it says seventh cranial nerve palsy, right seventh cranial nerve palsy, left hemiplegia. The problem is on the right side because right seventh nerve is affected, and because it is seventh, the problem is in the pons, right? So that is about the localization of lesions to the brainstem. Whenever the lesion is above the brainstem, we will have what we call as non-crossed hemiplegia. Means if the lesion is here above the brainstem, it could be subcortex or cortex, then cranial palsy as well as body weakness will be on the contralateral side. They are on the similar side. Like if I have right side, let us say this is left side. So if I have done left-sided subcortical or cortical damage, I will have right cranial palsy and right-sided hemiplegia. Lesion is on the left, right cranial palsy, right hemiplegia is what patient is going to get. We will call this as non-crossed hemiplegia. So the next level of localization is cortex and subcortex. They present with what we call as non-crossed hemiplegia. And what does that mean? Non-crossed hemiplegia means you have contralateral cranial nerve palsy or contralateral facial weakness, and you have contralateral hemiplegia. Contralateral hemiplegia. Now, how will I differentiate whether it is cortical or subcortical hemiplegia is the next level of discussion. So cortical hemiplegia versus non-cortical hemiplegia. Subcortical hemiplegia ideally. Subcortical hemiplegia. I hope you remember in the offline classes when we were discussing about it, I had specifically told you that in the cortex, all these neurons are sparsely distributed, but all their cell bodies, axons come down and form a compact structure in the subcortex. So when we do damage to subcortex, it does more damage, right? A damage to cortex will lead to less number of neurons being affected. So that's why the cortical hemiplegia is non-dense. Cortical hemiplegia is non-dense. Subcortical hemiplegia is dense. In cortical hemiplegia, either face and upper limb are more affected than lower limb, or lower limb is more affected than face and upper limb. In case of subcortical, the face, upper limb and lower limb are all equally affected, because in the subcortex, the face region, lower limb region, upper limb region, all the neurons come together in a compact tiny space. Damage here, everything will get equally affected. You go above and damage. Like if I do damage here, this area is for lower limb, so lower limb will be more affected. If there is a stroke here, this area is for the upper limb and face, so upper limb and face will be more affected. But when it comes to here, the face neurons, lower limb neurons, upper limb neurons all come together in a tiny space. Damage here, everything will get equally affected. So that is the first point. Then these cortical hemiplegia are often associated with aphasia, loss of consciousness and seizures. They are classically not expected in a patient with subcortical hemiplegia. That's why subcortical hemiplegia is often described as pure motor stroke. Weakness is the only complaint. They don't have any aphasia, loss of consciousness or seizures. So this is about localization. From here, I'm expecting, so far whatever we have discussed, I'm expecting one question. Maximum chances are that the questions will come from LMN versus UMN lesion. Okay, clear? Now with this backdrop, we will quickly start discussing the important neurotopics. And the first topic that we're going to discuss is going to be the neuromuscular junction disorders, that is myasthenia gravis and Lambert-Eaton syndrome. So when it comes to myasthenia gravis, what are the key points that you need to remember? Myasthenia gravis is a postsynaptic neuromuscular junction disorder. It is a postsynaptic neuromuscular junction disorder. Why am I calling it as postsynaptic? Because when you look at the neuromuscular junction, you have a nerve terminal, which is primarily the lower motor neuron, and its end is what we call as the nerve terminal. So this is lower motor neuron. This part is the nerve terminal. And on the other side of the nerve terminal, we have the muscle. So this part is the muscle. And the junction between the muscle and the nerve is what we call as neuromuscular junction. The nerve side membrane is called as presynaptic, muscle side is called as synaptic, and the space between the two is called as synaptic cleft. And normally what happens, LMN receives an electrical impulse from the UMN, and then it brings that impulse to the nerve terminal. Once it brings to the nerve terminal, here we have these specialized gates which we call as voltage gated calcium channels. So what are these? Voltage gated calcium channels. So these allow the entry of calcium into the nerve terminal. Once the calcium comes into the nerve terminal, we would have had vesicles which contain acetylcholine stored in them, acetylcholine containing vesicles, they degranulate and release. They degranulate and release the acetylcholine into the nerve terminal. And once that acetylcholine is released, it will go and bind to its receptors, trigger the second messengers, and cause the contraction of the muscles. And what kind of acetylcholine receptors we have here? The kind of acetylcholine receptors we have here are nicotinic type. Nicotinic acetylcholine receptors, right? So this is the basic neuromuscular junction. So what we need is, we need an electrical impulse to come to the nerve terminal that opens the calcium channels, which are voltage gated. Calcium comes in, causes the degranulation of acetylcholine containing vesicles. Acetylcholine is released, they bind its nicotinic acetylcholine receptors and then trigger intramuscular event that cause the contraction. Once the acetylcholine has done its job, it gets degraded to choline and water by choline and acetate by an enzyme called as acetylcholine esters, right? This is the basic neuromuscular junction physiology. If a muscle is affecting the nerve side of this junction, we will call it as presynaptic. If it is affecting the muscle side, we will call it as postsynaptic. And because in myasthenia gravis, antibodies are primarily or most commonly formed against this nicotinic acetylcholine receptor, we call it as a postsynaptic neuromuscular junction disorder. Right? It is due to antibodies against, what are the antibodies we see? Anti-acetylcholine receptor antibody. This is the most common antibody, and you should remember that when this antibody is positive, right, we call that kind of myasthenia gravis as seropositive myasthenia gravis. Seropositive myasthenia gravis, accounting for more than 85% of the cases. But in some patients, we may have anti-muscle specific kinase antibody. This antibody is the second most common antibody. If that is positive, we will call it as seronegative myasthenia gravis. Some patients, this may not be there. Instead, you may have anti-lipoprotein 4 receptor antibody. That is the least common antibody that we know in patients with myasthenia gravis. And if that is positive, we will call it as double negative, because acetylcholine receptor as well as MuSK are negative, but LP4 is positive. We will call them as double negative myasthenia gravis. And the important point to note here is that why we should know this antibody status, because for this particular antibody, we know where is its target antigen, right? So for this antibody, the target antigen is where? The target antigen for this antibody is in the myoepithelial cells of thymus gland. And that's why if it is a seropositive myasthenia gravis patient, thymectomy will be useful. If it is seronegative or double negative, their antigens are not there in the thymus gland, so thymectomy is not useful. Okay. So if that is the case, if antibodies are there, that also means that it is an autoimmune disorder. And if it is an autoimmune disorder, that means it will be more common in females. It is more common in females than males. And when it comes to the age distribution, it shows classical bimodal distribution. And when I'm talking about bimodal, you get one peak in that classical female age range where autoimmune disorders are common, the middle age or 20 to 40 years of age. But we also get another peak incidence in elderly. So after 50 to 60 years and in 20 to 40 years. 20 to 40 years, majority of the patients are females. And after 60 years, most are males. An elderly male presenting with myasthenia gravis generally carries poor prognosis. Okay, so in terms of clinical features, we already know the sequence of muscle involvement, right? What is the earliest muscle affected? Because in myasthenia gravis, the more I use the muscle, it loses the acetylcholine faster and loses the battle against antibodies faster. So the most used muscle is the one which will lose the battle first. And the most used muscle is levator palpebrae superioris. So because of that, the earliest symptom we are going to get is ptosis. And this ptosis separates the muscle disorders from neuromuscular junction, because both of them will eventually have proximal muscle weakness, right? But before, I mean, in case of the neuromuscular junction, we will have ptosis. We will not have ptosis in muscle disorders. You don't have ptosis in Duchenne muscular, Becker's, or any of the muscle dystrophies. After that, it is the extraocular muscles of the eye. Other extraocular muscles or muscles of extraocular movement, and that results in development of double vision or diplopia. If you diagnose a patient when they only have eye signs, we will call it as ocular myasthenia gravis. They have not yet developed other muscle involvement, right? They only have eye involvement. We call it as ocular myasthenia gravis. And I want you to remember one extra point here. When you're talking about ocular myasthenia gravis, eye muscle weakness, diplopia, ptosis can happen in third cranial palsy or multiple third, fourth, sixth cranial palsies. And we need to rule out them before we consider it as a case of myasthenia gravis. So that's why these patients need CT or MRI brain to rule out cranial nerve palsies before diagnosis. Okay, but after this extraocular muscles, we will have involvement of proximal muscles. And once the proximal muscles get affected, we will have the classical proximal weakness. Difficulty to comb, difficulty to get up from sitting position, difficulty to climb, difficulty to raise arm above the head, difficulty to lift objects. And when that happens, right, once the proximal muscles also get involved, we will call it as generalized myasthenia gravis. Okay, I'll write it down. So after proximal muscles, we can have the involvement progress to involve facial muscles. And remember, I have shown you an image in the offline classes. When facial muscles get affected, there is drooping of face. You will have drooping of face. And once there is drooping of face, you ask them to give a smile. They can't lift the lateral edge of the mouth. They will only be able to lift the philtrum or the middle portion of the lips, giving rise to a smile, which now we call it as myasthenic smile, but traditionally it was called as snarling faces, the dog-like expression, right? So drooping face with what we call as snarling faces. Because many doctors feel that's derogatory to use a dog's expression to humans, it is also now called as myasthenic smile. It's called as myasthenic smile. Okay, after the facial muscles, you may, in a worst scenario, rarely you have the involvement of respiratory muscles. If respiratory muscles get involved, we will call it as myasthenic crisis. Okay, so when you have all these manifestations, means eye as well as systemic manifestations, we will call it as generalized myasthenia gravis. Generalized myasthenia gravis. Okay, now the point to note here, as I've already told you, clinical features wise, these are the involvement of muscles. So these are the symptoms we are expecting. And the point to note, the weakness shows diurnal variation. Weakness increases with repeated use of muscles. Repeated use of muscles. And thus, because we keep using the muscle throughout the day, the weakness goes on worsening as the day progresses, right? So weakness worsens as day progresses. So they have maximum strength in the morning, and as the day progresses, their weakness goes on worsening. That's the classical myasthenia gravis. This is the point that should come to your mind whenever you think of myasthenia gravis. More I use the muscle, more weak it becomes. Lambert-Eaton is exactly opposite. The more I use the muscle, more strong it becomes. Now, when it comes to a patient presenting with these symptoms, for the diagnosis, remember there are multiple tests available and multiple MCQs can be asked for the diagnosis of myasthenia gravis. So first they will ask, what is the screening test? screening test. The screening test is going to be ice pack test. And what do you get in ice pack test? So when you put ice pack on an eye which is having ptosis, remember the repeated use of muscle makes it more weak. But if I put ice pack, the muscle is rested. We are not blinking anymore. So we are giving rest. The muscle is not being used. So it produces more acetylcholine. And once I remove the ice pack, the ptosis improves. So improvement on ptosis upon applying ice pack suggests that it is a case of myasthenia gravis. And that is the screening test of choice. Then they will ask what is the most sensitive and also the preferred investigation. Most sensitive and preferred investigation. So today the most sensitive and preferred investigation is single fiber electromyography. So what do we do in single fiber electromyography? We keep stimulating a muscle repetitively and we keep measuring its action potential. Repetitive stimulation in a myasthenia gravis patient should lead to decrease in the force of contraction, decrease in action potential. That response we call it as decremental response. Decremental response. That means decreasing muscle action potential on repeated stimulation. But some books, especially the Preplado Cubans, instead of calling it as decremental response, they call it as increasing jitteriness. What does that mean? If I contract a muscle fully, it's a contraction. But if I fail to contract, it's a jitter. So as I keep stimulating, initially it contracts. But as time progresses, the contraction starts becoming less. So the jitteriness goes on increasing, right? So either it can be mentioned as decremental response or increasing jitteriness. Both are same. Jitteriness means failed contract. So keep stimulating more, the contraction start failing more. That's the meaning of increasing jitteriness. So either you get a decremental response or increasing jitteriness. Then they may also ask you what is the most specific investigation. And remember, the most specific investigation is anti-acetylcholine receptor antibody, right? You also had an edrophonium test or tensilon test, which is not performed today due to increased risk of cholinergic crisis, right? So we have this edrophonium or tensilon test where we administer an acetylcholine esterase inhibitor and we expect the ptosis to improves on administration of acetylcholine esterase inhibitor like edrophonium or tensilon. And the point to remember about it is not routinely performed due to risk of cholinergic crisis. Okay, so that's about the investigation of myasthenia gravis. Now when it comes to management, we will divide the myasthenia gravis into stable cases and unstable cases, right? So myasthenia gravis, we will classify them into crisis and stable myasthenia gravis. So stable myasthenia gravis and myasthenic crisis. Myasthenic crisis. Myasthenic crisis means severe myasthenia gravis where apart from your eye muscles and proximal muscles, facial muscles, there is also involvement of respiratory muscles. So it is severe MG with involvement of respiratory muscles. And because respiratory muscles are involved, you will have respiratory weakness or respiratory failure or respiratory paralysis. And in such cases, in terms of treatment, because respiratory muscles are paralyzed, the first thing we should do is mechanical ventilator. Mechanical ventilator. And remember always, myasthenia gravis means battle between antibodies and the acetylcholine. And we want acetylcholine to win, antibodies to lose. So whatever antibodies are there which are fighting now for the acetylcholine receptors should be eliminated from the body. And that elimination can be achieved quickly by plasma exchange or plasma pheresis or using IV immunoglobulins. Okay, that's the crisis management. We don't use plasma exchange, plasmapheresis or IVIG for a stable patient. Only when they are in respiratory failure we use them. But for a stable myasthenia gravis patient, we try to increase acetylcholine by inhibiting acetylcholine esterase, right? And remember, the drug of choice for that is pyridostigmine, because pyridostigmine is long acting and does not cross the blood brain barrier. And to decrease antibodies, we follow various methods. One of them is steroids. Second one is using immunosuppressants or a combination of steroids and immunosuppressants. Third, we can get rid of the thymus gland, thymectomy, because antigen for the seropositive cases is present in the thymus gland, right? So this is thymectomy only for seropositive myasthenia gravis. And you know what do I mean by that? The seropositive means those who have anti-acetylcholine receptor antibodies, not the anti-MuSK or anti-LP4 receptor antibodies. Seropositive myasthenia gravis patients aged less than 50 to 55 years. Anything higher than 55 years is not considered safe for the thymectomy. Even though they have antibodies, they may not be physically safe for the surgery. That's why we avoid it. So, but anyone who is young, like 40, 45, and they present with myasthenia gravis and they have anti-acetylcholine receptor antibody, get rid of the thymus gland, the disease is cured. Thymectomy can be curative, right? So that's about our case of myasthenia gravis. Now we are going to also discuss a little bit about Lambert-Eaton syndrome. Myasthenia gravis is one neuromuscular junction disorder, and then next we have Lambert-Eaton syndrome, which is another neuromuscular junction disorder. And you must be knowing that Lambert-Eaton is somewhat similar and dissimilar to myasthenia gravis. So what are the similarities? The similarities for the Lambert-Eaton are that it is also an NMJ disorder, but this is a presynaptic. It is a presynaptic neuromuscular junction disorder. It's a presynaptic neuromuscular junction disorder. Second thing, it is due to antibodies against voltage gated calcium channel antibodies. And this voltage gated calcium channel is on the nerve side. That's why it is a presynaptic neuromuscular junction disorder. But unlike the myasthenia gravis, this is not an autoimmune disorder. It is a paraneoplastic syndrome. And paraneoplastic syndrome are the manifestations of cancers, right? So they ask you what is the most common cancer associated. The most common cancer associated is the oat cell or small cell lung cancer. Small cell lung cancer. It's a potential MCQ point. They may ask you directly what is the most common cancer associated with Lambert-Eaton, or the question may open like this. So here is a patient who is a known small cell lung cancer case. He presented with some weakness. So already the examiner is setting the stage for you to think about Lambert-Eaton syndrome. Okay. Now for the diagnosis here, again we will go ahead with the single fiber electromyography. But remember, in Lambert-Eaton, the more I use the muscle, I forgot to mention the weakness. So here, the repeated use of the muscle improves weakness. Use of muscle improves weakness. That's why as the day progresses, their weakness goes on improving because they're repetitively using the muscles. And that's why when we do single fiber electromyography, the more I stimulate the muscle, the force of contraction goes on increasing. The cardiac muscle action potential goes on increasing. We will call that as incremental response. Incremental response. So the first stimulus of an electrical impulse may not give me much contraction. That was a jitter. Second, little more contraction, but it's still a jitter. But third, a proper contraction. Fourth, stronger contraction. Fifth, even stronger contraction. So preparator may mention it as decreasing jitteriness, or we will call it as incremental response. So muscle action potential increases with repeated stimulation. or this may be mentioned in some apps as decreasing jitteriness. Both mean the same thing. Okay. Now, once you're diagnosed, when it comes to the management, remember, treating underlying cause is the mainstay of treatment. Like in case of the myasthenia gravis, if I had seropositive thymus gland, remove it, problem solved. Similarly, here you have a small cell lung cancer. If it is treatable with radiotherapy, surgery, or whatever form, treat it. The problem solved. If not treatable, recent times there are few drugs approved which I might have covered for some batches and might not have covered from some batches because they are quite recent updates. So there are some recent drugs. So the first drug is diaminopyridine, 2,3-diaminopyridine, or simply diaminopyridine. It's a presynaptic potassium blocker. Presynaptic potassium blocker. Not greatly effective. To some extent, it helps patient symptom improvement. And then the second drug is called as torusodiol. This drug was approved recently and then again withdrawn recently. Like before we could see it being used in India, it was approved and withdrawn. So question may be asked, withdrawn due to negative trial. What do I mean by that? It was initially approved because theoretically it is supposed to help, but once it is approved and marketed, in whichever patient it was used, it did not show any symptomatic improvement. So the post-marketing trials failed to show the improvement. That's why it has been withdrawn. So two potential MCQs. This is useful. So it continues to be approved. But the torosodiol, it is withdrawn because of the negative trial. Okay. So this is about our Lambert-Eaton syndrome. Okay. So next up, we have GB syndrome. Okay, so what are the differences between the myasthenia gravis and Lambert-Eaton? Myasthenia gravis is postsynaptic. The single fiber electromyography shows decremental response. Lambert-Eaton is presynaptic. The SAPMG shows incremental response. Myasthenia gravis, we try to increase the acetylcholine. Lambert-Eaton, we try to treat the underlying cause, and just to give little bit of symptomatic benefit, we use diaminopyridine, which is the latest new drug. Diaminopyridine. Another new drug came out with a lot of hope, but taken away from the market because of negative trial. Okay. Next, we are going to discuss about is GB syndrome. So what is this GB syndrome? GB syndrome is an acute post-infectious polyneuropathy, right? It's an infection-triggered polyneuropathy. Infection-triggered autoimmune polyneuropathy. And when we are talking about infections, of course, there comes the question, most common infection. Most common infection is Campylobacter jejuni. But any infection may be responsible, including vaccines, can trigger GB syndrome. And then if it is autoimmune, then comes the question, which antibodies? Right? Is it antibody mediated? Yes, it is antibody mediated. What antibodies are responsible? There are different types of antibodies responsible. One of them is anti-ganglioside M1 antibodies or anti-GM1 antibodies. And when these antibodies are present, these antibodies cause damage to the myelin sheath. So it presents as acute inflammatory demyelinating polyneuropathy, where the myelin is demyelinated. It affects both motor as well as sensory. Motor as well as sensory neurons get affected. And then you have another antibody called as anti-GD1A antibodies. And these antibodies have their target antigen on the axon, so it causes axonal injury. That is AMAN, acute motor axonal neuropathy, or AMSAN, acute motor and sensory axonal neuropathy. So AMAN is a pure motor variant where only motor neurons are affected, and if time is given, eventually sensory neurons will get affected, and then it becomes AMSAN, motor plus sensory. So here the injury is both axonal, as here the injury is axonal. AIDP is demyelinating type. Then we have one more, relatively less common. Remember, AIDP is the most common variant of GB syndrome, and Aman Amsan are the second most common. This is relatively less common, where we have anti-GQ1B antibodies. Remember the logic I had given you. In India, Q is rarely followed. So this is a rare variant where you have Q1B antibodies. And that disorder is called as Miller-Fisher syndrome, right? It's called as Miller-Fisher syndrome. There are some peculiarities about the Miller-Fisher syndrome. Miller-Fisher syndrome predominantly affects sensory more. It affects sensory more than motor. So motor neuron involvement is rare in Miller-Fisher. Because it is predominantly affecting the sensory neurons, and one of the sensation, proprioception, is important for me to maintain the upright posture, because constantly my brain should get to know in what all positions my joints are there, whether they're like this, whether they're like that. My brain should know the position of my joints, and position of joints going to the brain is proprioception. If that is taken away, brain doesn't get to know whether I'm upright or tilted. So I will have ataxia. These patients will have ataxia plus ophthalmoplegia. Means cranial nerves going to the eyes can get involved, right? And rarely they will have motor weakness. And because these variants have motor weakness rarely involved, the prognosis seems to be good. So the first question they may ask from here is, which all variants have good prognosis and which all variants have bad prognosis? So in terms of prognosis, when it comes to prognosis, the Miller-Fisher syndrome and AIDP tend to have good prognosis. And Aman and Amsan, these are axonal variants. Axonal injury is more difficult to recover, and because of that they carry poor prognosis. But if they ask you which carries worst of all prognosis, not these. There is one more variant which is very rare, very rare, and that variant is Bickerstaff encephalomyelitis. It is called Bickerstaff encephalomyelitis. So what does that mean? Encephal means brain, myel means spinal cord, means both are CNS. So this variant is also an important MCQ about this variant is, it is a GBS variant with CNS involvement. With CNS involvement. There is no other GBS variant where CNS is involved. AIDP, Aman, Amsan or Miller-Fisher. CNS is not directly involved. The ataxia is because of the sensory nerve involvement in Miller-Fisher syndrome, right? And because CNS is affected apart from the PNS, this carries the worst prognosis. Okay, so this is about the prognosis. Now talking about the clinical features. The clinical features of GB syndrome. They have classical presentation. What is that? They will have rapidly progressing ascending paralysis. Ascending paralysis. Some extra point to note here from which the MCQs are asked usually. What is that? The progression, the phase where the disease is progressing, lasts for less than 4 weeks. Progression lasts less than 4 weeks. Okay. And because it is a disease of peripheral nerves contain lower motor neurons, and because lower motor neurons are the one which is either having demyelination or axonal injury, depending on which type it is, we will have decrease in muscle tone and decreased reflexes. So you will have hypotonia or flaccidity and you will have hypo or areflexia. Areflexia. Sensory involvement is usually there in some variants, not in some. Like AIDP, we have sensory involvement. AMSAN, we have sensory involvement. Miller-Fisher, so predominantly sensory it is. But AMAN is pure motor, where there is no sensory involvement. It's a pure motor variant. That's again an important potential MCQ point. Which one is a pure motor variant? Okay. Now these are the clinical features. These patients can die. Death is most commonly due to respiratory failure. Death is most commonly due to respiratory failure and related complications. Okay. Now, if I have to diagnose these patients, if someone presents with rapidly progressing ascending paralysis with flaccidity and hyporeflexia, for diagnosis, currently we follow a criteria which is called as Brighton's criteria. And the Brighton's criteria says that there are few parameters that you need to remember. 3 are clinical, 2 are lab based. The clinical parameters are you should have an ascending paralysis. Because remember, in polyneuropathy, GBS is a acute polyneuropathy. And in polyneuropathies, the longest neurons get affected first. Longest are going to the distal body parts. That's why distal gets affected first. So you'll have ascending paralysis. Ascending paralysis, I've already told you, the progression should last for less than 4 weeks. If it lasts for more than 4 weeks, it is suggestive of CIDP, chronic inflammatory demyelinating polyneuropathy. Then there should be flaccidity or hypotonia, and there should be hypo or areflexia. So these are 3 clinical parameters which we have already discussed. And then we will take help of lab. So in the lab, we are doing 2 things. One, nerve conduction study. Second is CSF analysis. So in nerve conduction study, either you will have features of demyelination. In which variant we have demyelination? In AIDP, we have demyelination. In Miller-Fisher, we have demyelination. And in which variants we have the axonal injury? In AMAN and AMSAN, we have axonal injury. So a nerve conduction study can show the presence of demyelination or axonal injury. One of them should be evident. In the CSF, remember these antibodies, the anti-GM1, anti-GD1, GQ1, all that we spoke about, these will make their way into the CSF. And these are essentially what? Immunoglobulins. Immunoglobulins are proteins. So CSF protein increases. Cell count doesn't increase. And this phenomenon we call it as albuminocytological dissociation. Very important examiner's clue. If he's talking about so-called albuminocytological dissociation in a question, he's giving you a clue. He's giving you a hint that I'm talking about GB syndrome. So there will be increase in CSF protein, but the CSF cell count remains less than 50. It doesn't grow high. This finding, collectively, we will call it as albuminocytological dissociation. So when these features are there, according to Brighton's criteria, it is a case of GB syndrome. And once you diagnose it as GB syndrome, we will talk about its management. And when it comes to management of GB syndrome, the point to note is that the main worry is the paralysis eventually involving respiratory muscles, which can kill the individual. And I don't want it to progress there. And the best way is, the more antibodies are produced, more antibodies will cause more nerve damage, and eventually respiratory muscles will get affected. So if I stop or eliminate the antibodies from the body, the problem is solved. So in terms of treatment, we can either follow IVIG or plasma exchange or plasmapheresis. In terms of superiority, I have already told you that IVIG is slightly superior. So if both options appear in the question, plasmapheresis as well as IVIG, I would suggest you to go ahead with the IVIG because it is more superior. This is slightly superior in efficacy. And another important MCQ they may ask you is, how do you monitor them developing respiratory paralysis, right? We have to monitor them for respiratory paralysis not using hourly ABG or SpO2, but rather by monitoring forced vital capacity, right? And they may ask you when the intubation is indicated. If forced vital capacity drops to less than 15 ml per kg, intubation and ventilator is indicated. These are again potential MCQ point. Okay, clear? That's about our GB syndrome. So from the GB syndrome, 2-3 kinds of questions are asked. First thing is clinically recognizing GB syndrome. The story goes simple. Patients will have a diarrhea or dysentery. Then they present with ascending paralysis. The question is talking about GBS. Second, then after that, they may ask which of the following is not seen or is seen. Remember, GBS is a lower motor neuron disease. So as long as you remember this, you should be able to answer majority of the clinical questions, symptom related questions. Then there may be another question regarding the subtypes. Easy to remember. It is there in the name. AIDP, it is demyelinating type. Aman Amsan, axonal injury type. They may ask antibodies and their correlation of type. So remember GM1, general merit. This is the most common variant, most common category for admissions in any courses, general merit. So general merit for most common. And Miller-Fisher is the rare variant. And for rare, Q in India is rare. That's how you have to remember it. Okay. So after the GB syndrome, let's go to a disease which we call it as amyotrophic lateral sclerosis or ALS. Amyotrophic lateral sclerosis or ALS, which is also called as Lou Gehrig's disease. Lou Gehrig's disease. So what is this? Like we studied about GB syndrome, that was a LMN disorder. Then we also studied about the myasthenia gravis and Lambert-Eaton. These are disorders of neuromuscular junction. These are neither LMN nor UMN. It is a separate structure. Now we are going to talk about a disease which is a motor neuron disease, right? What is it? It is a motor neuron disease. It's a motor neuron disease. Now, what do you mean by motor neuron disease? A motor neuron disease is one where only motor neurons are affected. Adjacent other neurons are not affected. Only purely motor neurons are affected. Like if I damage spinal cord, motor, sensory, autonomic, all gone. If I damage a peripheral nerve, motor, sensory, autonomic, all gone. If I damage brain in a particular area, whatever neurons are there, motor, sensory, higher mental functions, all gone. But if I selectively only damage motor neurons, then we call it as motor neuron disease. And ALS is one. And this is a motor neuron disease where there is death of UMN as well as LMN. Polio is a classical example for a pure LMN motor neuron disease where the polio virus kills the cell bodies of lower motor neuron. Then lathyrism is a classical example for pure UMN motor neuron disease where the toxin BOA, beta oxalylaminamine, only kills the upper motor neurons. But in ALS, both UMN and LMN are affected, and it is a neurodegenerative disorder. It's a neurodegenerative disorder. And what do I mean by that? That means in these disorders, the death of neurons happen because of accumulation of something, due to accumulation of. So what is accumulating here? Due to accumulation of two substances. One of them is tar derived protein 43, TDP 43. Second one is ubiquitin immunoreactive proteins. Ubiquitin immunoreactive inclusions or proteins. Now, we don't know the exact cause for amyotrophic lateral sclerosis. We only know the risk factors. And when it comes to risk factors, the key risk factors I want you to remember is age more than 55 years, that is elderly people. And then genetics plays an important role. And when we're talking about genetics, mainly I want you to remember mutation in ORF and superoxide dismutase 1 genes. These mutations are increasing the risk of someone developing amyotrophic lateral sclerosis. And when they develop, the randomly UMNs and LMNs start dying. So what clinical features they will present with? They will have a classical presentation because UMN and LMN exist in two tracts. One is for the body, that is pyramidal tract contains UMN, peripheral nerves contains LMN. And for the head and neck, corticobulbar tract contains UMN and the cranial nerves contain LMN. So UMN and LMN in the corticobulbar and cranial nerves can also die. and UMN in the pyramidal tract and LMN in the peripheral nerves can also die. So the involvement of the pyramidal tract UMNs and peripheral nerve LMN produces progressive weakness of the limbs, right? So one of the complaint is going to be progressive limb weakness with few muscles who have lost elements showing LMN findings, and few muscles who have their elements intact but UMN gone. They will be showing UMN findings. This is a classical picture. In one patient, you have LMN findings as well as UMN findings. And if this appears in any MCQ, there are some rare conditions where you can have it, but for an undergraduate student, an FMG student, if any question talks about multiple muscles showing weakness, some showing UMN findings, some showing LMN findings, close your eyes and choose the answer amyotrophic lateral sclerosis. For you, there is no other differential diagnosis, right? As simple as that. ALS is equal to some muscles showing LMN, some muscles showing UMN findings, some muscles showing hyperreflexia, hypertonia, some muscles showing hypotonia, hyporeflexia. That's it. Done. Okay. And this progressive limb weakness is the one that makes them wheelchair bound, like you see in case of Stephen Hawking. Plus, in addition to that, they will also have, because the cranial nerves also are losing UMN and LMN, so they can have bulbar or pseudo-bulbar palsy. Bulbar or pseudo-bulbar palsy. And when I say bulbar palsy, means the lesion at brainstem, means cranial nerve nuclei are being affected. That is classical LMN type of cranial palsy. And when you say pseudo-bulbar, the lesion is above the bulb. Bulb is brainstem, right? That means the lesion is in corticobulbar tract. Lesion at corticobulbar tract. That is UMN type of cranial nerve palsy. One of them can happen. And when that happens, right, what symptoms these bulbar or pseudobulbar palsy going to present? They will present with the classical 3Ds. Can anybody tell me what are those 3Ds of bulbar or pseudobulbar palsy? Dysphagia, dysphonia, and dysarthria. And these are the exact reason why Stephen Hawking had to use a voice synthesizer to speak, right? So any question which talks about progressive limb weakness along with dysphonia, dysphagia, dysarthria is equal to ALS. Any question which talks about progressive limb weakness with some muscle showing LMN, some muscle showing UMN finding is equal to ALS. Now, once we're suspecting that it could be a case of ALS, for diagnosis, we are following a criteria which we are going to call it as L-Escorial criteria. So what this criteria says, in this criteria, body is divided into different regions. The head and neck is called as bulbar because the nerve supply comes from cranial nerves which originate in the bulb or brainstem. Then the limbs, the upper limb are called as cervical. Chest and abdomen is called as thoracic because cervical segments give the nerve supply to the upper limbs. And thoracic segments are the ones which are giving the nerve supply to the thorax and abdomen. And the lumbosacral segments of the spinal cord are giving the nerve supply to the lower limb. So we will call them as lumbosacral. So this is one lumbosacral region. This is another lumbosacral region. This will be a thoracic region. This will be a bulbar region. And these will be my cervical region, right? The body will be divided into upper limb as cervical region, head and neck as bulbar region, chest and abdomen as thoracic region, and lower limb as lumbosacral. And what L-Escorial criteria says, if I find UMN plus LMN findings in more than or equal to 3 regions, more than or equal to 3 regions, that is equal to definitive ALS. That means we have definitive amyotrophic lateral sclerosis. So what MCQ they will ask so far, in even in NEET PG, the maximum they have asked is how many regions should show LMN and UMN findings. If 3 regions of the regions that we have listed here show LMN and UMN findings, it is amyotrophic lateral sclerosis on a clinical grounds without any investigation. Okay. Once you have diagnosed, we should also know that they are at high risk of death. The most common cause of death is one, bulbar or pseudobulbar palsy leading to aspiration, because they have dysphagia, they have difficulty to swallow, and that leads to aspiration of food, and they can develop aspiration pneumonia and die. So aspiration pneumonia is one of the most common causes for death. And the second most common cause for death is if the thoracic segments is where UMN or LMN are dying, that can result in respiratory failure. So when it comes to the management, unfortunately, supportive management is important. I'm not going to list the features that we do in supportive management. Basically, speech is difficult, so we'll give voice synthesizer. Aspiration pneumonia risk is there, so we will do a PEG tube. Those are the basic things, right? Supportive care is there. And then in terms of pharmacotherapy, we had drugs that could be used. The first drug that we are thinking about when it comes to pharmacotherapy is riluzole, and the second drug that we have in terms of pharmacotherapy is edaravone. Riluzole and edaravone, these are drugs that are useful. These are antioxidants, or you can say free radical scavengers. They increase survival by approximately 3 months. And we have a new drug, and the new drug is tofersen. Tofersen is an antisense oligonucleotide for superoxide dismutase 1 mutation. That means it is only useful for SOD1 mutation carrying ALS. And torosodiol, another drug, withdrawn due to failure in trial. That's about the ALS, right? So mostly questions will be either about tofersen, where it is useful. It is useful for those patients who have superoxide dismutase 1 mutation. Second, recognize that this patient is having ALS. And how do you recognize? 3 Ds, dysphonia, dysphagia, dysarthria with limb weakness is equal to ALS. Or second way is progressive limb weakness with some muscle showing UMN, some muscle showing LMN findings, right? That's how you are going to recognize. The next topic that we're going to discuss is multiple sclerosis. So what is multiple sclerosis? Multiple sclerosis is a demyelinating disorder of CNS. It's a demyelinating disorder of CNS. And I think I have told you that this is a condition which is comparable to alopecia areata, where there are multiple attacks of demyelination of the central nervous system, and every time it's going to be a different structure that is going to get affected. The demyelination does not affect the same structure always. Sometimes it affects the sensory tract, sometimes it affects the motor tract, sometimes it affects the brainstem, sometimes it affects the cerebellum. So symptoms are not going to be constant. Symptoms will depend on the site where demyelination is happening. Demyelinating disorder of the CNS characterized by recurrent attacks affecting different anatomical sites. This is also an autoimmune disorder, and being an autoimmune disorder, so you should remember that it is due to cell mediated plus antibody mediated. So there is a cell mediated injury plus antibody mediated injury. And when we are talking about antibody mediated, the main antibody is anti-myelin basic protein antibody, right? This is the most common antibody, and which is targeting which cells are responsible for the myelination of the CNS. PNS, it is Schwann cells. In the CNS, it is oligodendrocytes. So oligodendrocytes are the targets for this antibodies, and that's why you are getting demyelination. There are some other antibodies like anti-myelin, oligodendrocyte, glycoprotein antibody and all, but the main most common antibody is anti-myelin basic protein antibody. Okay. Now, because of that, these patients go through, and because it is an autoimmune disorder, I should tell you that it is typically more common in females than males. Usually middle-aged females are the most affected, and when I say middle-aged, we are referring to 20 to 40 years of age. That's the usual age. The ratio is 4:1, and it is typically more common. The risk factors for this include vitamin D deficiency, then Epstein-Barr virus infection, These are the important risk factors, and that's why as we move away from the equator, the incidence of multiple sclerosis increases. On the equator, like India, which is closer to equator, the incidence is less. But now with rising vitamin D deficiency, multiple sclerosis cases are also increasing in India. Okay. Now, in terms of clinical features, I can't say one standard feature. Why? Because different structures get demyelinated at different times. So whichever structure gets demyelinated, you will have that symptom. So what is the most commonly affected site by demyelination? The most commonly affected site by demyelination is the sensory tracts in spinal cord. And if they get affected, what symptom we are expecting? So in terms of symptoms, we are expecting loss of sensations and paresthesia. Loss of sensations and paresthesia. These are the commonest symptoms of patients with multiple sclerosis. Okay. Then you have to also remember that when the spinal cord multiple sclerosis affects, it affects less than 3 spinal segments. Means demyelination of a sensory tract will not run for this whole journey of the tract. The tracts begins at the bottom of the spinal cord, and these are ascending sensory tracts. Only 1, 2 or 3 segments is where demyelination happens. The remaining segments are unaffected. There is another differential diagnosis for multiple sclerosis, which we call it as neuromyelitis optica, where you will have demyelination affecting more than 3 segments. This is an important point that I want you to remember. Then the second most commonly affected is optic nerve. And when optic nerve gets affected, it produces what we call as vision loss. And usually in multiple sclerosis, the involvement is unilateral. Only one side optic nerve gets demyelinated, and that leads to only vision being affected on one eye. So monocular vision loss is a symptom you can see. There are other structures that can get affected. So what are the other structures affected? The other structures affected are, you can have involvement of cerebellum. Cerebellum can get demyelinated, and when cerebellum gets demyelinated, what symptoms do we expect? we can get ataxia, nystagmus, and action tremor or intention tremor. Okay, so there are long list of symptoms we can get: ataxia, nystagmus, action tremor. Other than that, you can also have dysdiadochokinesis. What do I mean by that? Inability to do rapid alternating movements. Dysdiadochokinesis. So these are symptoms we can get because of involvement of cerebellum. Okay, then there can be demyelination of pyramidal tract. And when pyramidal tract get demyelinated, it will produce motor weakness. And even brainstem can get demyelinated, and when you have brainstem demyelination, you can have, because brainstem have cranial nerves, you can have cranial nerve palsies apart from motor weakness. So these are all symptoms we can get. What symptom the patient will come to hospital with depends on which structure is getting demyelinated. Now when we get such a patient, for diagnosis, we are going to do some basic investigations, and then we will be following what we call as the McDonald's criteria, right? So first we will look at investigations. So investigation wise, I want you to remember two. One is you can do MRI. MRI is a good investigation for the identification of demyelination. CT is not good. CT is good for bleed. Second thing we are going to do is CSF analysis. And in the MRI, the demyelinated site, wherever there is demyelination, it will appear as oval hyperintensity. It will appear as a oval shaped hyperintensity or signal change. And can anybody tell me, we have discussed about demyelination affecting the corpus callosum, where it appears that finger-like projections are coming out from the ventricle. What do we call that as? Can anybody tell me, where do you get that and what do you call it as? Of course, we get it in myasthenia gravis, but what is it called? Sorry, multiple sclerosis. What is it called as? So these oval finger-like projections that you are getting, oval-shaped hyperintensities, appear to come out from the ventricle. We will call them as Dawson's finger. So I want you to remember what is this. Dawson's fingers. Oval hyperintensities appear to arise from the ventricles. So they are pointing towards demyelination of corpus callosum, and we will call them as Dawson's fingers. And when we do CSF analysis, this anti-myelin basic protein antibody and other antibodies have reached the CSF. So there is increase in the CSF protein. And I forgot to mention this point. This antibody that we are talking about, this is actually IgG type of antibody. It is an IgG type of antibody. And normally in CSF, we do not have IgG. So if I do an electrophoresis, I will be able to see IgG, which is normally not seen in the CSF. And in whichever area, that band where we see IgG, that band is called as oligoclonal bands. These are called as oligoclonal bands due to presence of IgG antibodies in the CSF. Remember the workbook, we have this classical picture. In normal CSF, normal plasma has IgG, but normal CSF has no IgG. But once the IgG appears in the CSF also, it forms a band at where we see IgG in the plasma. So this band is what we call as oligoclonal band, right? So remember, these are potential MCQ points. Dawson's fingers and oligoclonal bands, usually abbreviated as OCBs. These are very, very important MCQ points, repeatedly asked. Both of them have been repeatedly asked. That is about investigation. But when it comes to neurological diagnosis, if you have followed me, you know that it is mostly clinical, and clinical diagnosis is possible without investigation by following what we call as McDonald's criteria. What McDonald's criteria said, to call it as a case of multiple sclerosis, you need to meet two parameters. What is that? We will call it as definitive MS if two parameters are met. The first one, there should be evidence of more than or equal to 2 events of demyelination demyelination disseminated in time, and there should be more than or equal to 2 events of demyelination disseminated in space. What do I mean by disseminated in time? There should be history of 2 events happening in patient's life which are separated in time by more than 1 month. Separated by more than or equal to 1 month. So if in Jan 2025 I had demyelination of cerebellum and I have all the symptoms and I had come to you, and then March 2025 I developed demyelination of sensory tracts and I developed symptoms of sensory loss and I come to you, there are 2 events which are separated by more than 1 month. Then dissemination in time criteria is satisfied. Plus I also need the evidence of 2 events of demyelination which are disseminated in space. Space means anatomy, means 2 different structures should be affected. At least 2 different structures should be affected. I just gave you a story. Jan, I had cerebellar symptoms. March, I had sensory symptoms. They are separated by more than 1 month, so dissemination in time is satisfied. At the same time, Jan, it was affecting cerebellum. Now it is affecting sensory tract in the spinal cord. So 2 different anatomical structures, the space is different. So dissemination in space is also satisfied. These patients I don't have to investigate in detail. On clinical grounds itself, I will call it as definitive multiple sclerosis. If you have to diagnose on clinical grounds, and if any of these criteria are not met, like okay, let us say in Jan I had cerebellar symptoms. In March again I have cerebellar symptoms. 2 events, they are separated by more than 1 month, so dissemination in time is satisfied. But it does not satisfy dissemination in space because Jan also cerebellum, March also cerebellum. So this criteria is not satisfied. In that case, if I have to diagnose clinically, what should I do? I have to wait for one more event of demyelination happen. Maybe 4 or 5 months later, patient comes with motor weakness. Now previously cerebellum, now pyramidal tract, 2 different anatomical structures. Now dissemination in space is also satisfied. Then I can label it as definitive multiple sclerosis according to McDonald's criteria. Otherwise, you can always take the help of investigations to establish the diagnosis. Now, once you have diagnosed, before we go to the management, we will quickly recap about the disease behavior. Disease behavior. So based on how the disease behaves, we have different types of multiple sclerosis. And for those types, you should remember the graphs that we had sketched. So there are 3 major types. The first one and the most common is where there will be multiple episodes of demyelination. So this graph is plotting time on x-axis, and on y-axis we are plotting the disability. And remember, for disability monitoring we are using a scale which is called as Kurtzke's expanded disability severity scale. According to that, we will plot the disability over time. And in the first type, every time demyelination happens, disability increases. Some structure got demyelinated, it does not work now, disability increases. But again, disability comes back to where it was, means the demyelination got remyelinated. But patients will go through recurrent attacks of demyelination, but every time there is demyelination, there is near total recovery. This type is the most common type, and this type we are going to call it as relapsing and remitting type of multiple sclerosis. This is the most common type, accounting for more than 85%, and it carries good prognosis because though multiple times demyelination happens, every time he makes complete recovery. Okay. Then the second graph kind of looks like this. Every time demyelination happens, some part of the brain stops working, disability increases, but he does not make total recovery. Partial recovery or no recovery, and then another episode of demyelination happens, adds to more disability. So the disability just goes on increasing in these patients. Like one episode, let us say cerebellum got demyelinated, so I had ataxia. So ataxia is there, it did not improve, it was remaining, I'm ataxic. Now I also had the demyelination of pyramidal tract, so now I am having weakness of limbs. My disability increased because now I'm ataxic and limb weakness. And then I have optic nerve demyelinations, I lost vision in one eye. So now I'm ataxic, I have motor weakness, and I can't see from one eye. My disability just went on increasing. I never recovered. This type is called as primary progressive multiple sclerosis. This is called as primary progressive multiple sclerosis. This is the second most common type, and this definitely carries poor prognosis. Poor prognosis. The third one looks like the amalgamation of the top two graphs. We will call it a secondary progressive multiple sclerosis, where initially every time demyelination they were making complete recovery, so graph was returning to baseline. But as time progressed, the recovery stopped, and then the events of demyelination kept him more and more disabled. So it looks like a combination. First half looks like relapsing and remitting. Second half looks like primary progressive. This graph is called as secondary progressive. This is less common. This is less common, and we would say this carries modest prognosis. Why I am calling it as modest prognosis? Because at least initial few events of demyelination, patient was able to recover. Later, recovery stopped. Here, from the beginning only, no recovery. That's why it carries poor prognosis. So these are the three variants based on the disease behavior. We have some rare variants that you need to remember. And these rare variants are acute variants. So one of them is called as Marburg variant. In Marburg variant, multiple episodes of demyelination happen in quick succession within short span of time. That's why it is an acute variant, and this carries the worst prognosis. Among all, the worst prognosis is by Marburg variant. Second one is called as concentric sclerosis of Ballo. Concentric sclerosis of Ballo, where you catch hold of the patient before the demyelination is complete in that particular area, giving rise to alternative bands of demyelination and no demyelination. So we'll call it as onion ring appearance. So in concentric sclerosis of Ballo, that you can see partly in this picture also, where you can see there is a ring. The gray colored zone that you see has not yet lost the myelin. There is still myelin present, but that white rim that you see has lost the myelin, demyelinated. Another gray rim that you see has not lost the myelin, right? But then the peripheral white rim that you see has lost the myelin. So there are alternate bands of myelin being present and demyelinated region. This is what you call as concentric sclerosis of Ballo, or the radiological appearance called as onion ring appearance, right? So these are basic MCQ points. Now that we know to classify based on the disease behavior, again I'm urging you to remember what is the tool used to assess the disability in these patients using Kurtzky's expanded disability severity scale. Then comes the management. So when it comes to the management of multiple sclerosis, first point to remember is it's a disorder where there is a recurrent attacks of demyelination. So we have to think of prevention plus whatever demyelination that is ongoing currently, we have to think of stopping it so that remyelination starts. So that's why the MS management will be divided into acute treatment and preventive treatment. Acute treatment is primarily to stop ongoing demyelination. There is a demyelination going on, we want to stop it. And preventive is to prevent future events of demyelination. So the acute treatment primarily focused on, remember I have already told you this is a condition where there is cell mediated injury as well as antibody mediated, right? The cell mediated can be immediately halted by giving steroids. So the mainstay of treatment is going to be high dose methyl prednisolone. We can use IVIG or plasma exchange, but cells can be better suppressed by high dose methyl prednisolone, that is 500 milligrams to 1 gram or 1000 milligram per day IV OD for 3 to 5 days. So that halts or stops whatever demyelination that is going on. Further demyelination won't happen once you give this high dose of methylprednisolone. And once the demyelination stops, the body will slowly start remyelinating. But after a few months, you may have another episode of demyelination that I want to prevent. So for that, we need to choose drugs. And when it comes to choosing the drugs, that is where the disease behavior comes into picture. So if I'm dealing with what we call as primary progressive multiple sclerosis, as of now, there is only one drug which has stood the test of time on clinical grounds and or the clinical trials, and that is ocrelizumab. Ocrelizumab is a monoclonal antibody against cluster of differentiation 20. CD20 is a marker of B lymphocytes, and B lymphocytes are the ones which are producing the antibodies. So if I block them, antibody production comes down. So if there is no antibody, no demyelination. That's what we believe. But for the other types, that is the relapsing and remitting multiple sclerosis and secondary progressive multiple sclerosis, we have a long list of drugs. So what are the drugs we have? We have drugs like dimethyl fumarate, then fingolimod, ozanimod, siponimod, and then natalizumab, which is again anti alpha 4 integrin, anti alpha 4 integrin monoclonal antibody. Max, they will ask you what is its mechanism, nothing more than that. Okay. Then we have rituximab, which is anti CD20, which you're all familiar because of chemotherapy and onco, anti CD20. And then we have ocrelizumab, which is again anti CD20. So effectively making ocrelizumab as the only drug which can be used for both. This can be used for both the relapsing remitting and secondary progressive group as well as the primary progressive group. There is no other drug which can be used in all the cases, right? Clear? Ocrelizumab is the only one that you can use in all the variants. So that is a potential MCQ. Drug useful for preventive treatment of all variants. You don't have to look at the variant, what variant it is, then it is ocrelizumab. That completes about our multiple sclerosis. I forgot to mention there are some ancillary symptoms that you need to be aware in multiple sclerosis, which are again used in the exam as potential clues. What are those ancillary symptoms? Hermitage sign, Uthoff's phenomenon, and Pulfrich phenomenon. What are these Hermitage sign? When suddenly neck is flexed, patients will have shock-like sensation. What is Uthoff's phenomenon? Whatever is the demyelination, whatever symptoms they have, those symptoms become worse on exposure to heat. Like if the ambient temperature is high, patient takes hot water bath or develops fever, the symptoms become worse transiently. As the body cools down, the symptoms get back to the baseline. You call it as Uthoff's phenomenon. And Pulfrich phenomenon is typically seen when there is monoocular vision loss or demyelination of one optic nerve. So the conduction of the image to the brain is slowed down through the demyelinated nerve and it is normal through the other nerve. So I receive the same image twice, once through the normal nerve, once through the slow conducting demyelinated nerve. The brain cannot process this two information of the same image coming at two different time frames. So it starts presuming all two-dimensional events as three-dimensional. We call it as Pulfrich phenomenon. Okay, these are additional symptoms that you need to remember because any question which mentions these Hermitage sign, Uthoff's phenomenon, and Pulfrich phenomenon is talking about multiple sclerosis. Clear? Okay. Now, the next extra thing that we need to know, okay, for those who want to use the notes, I will write down the ancillary symptoms. Because they may ask some direct questions on them. The first ancillary symptom is Hermitage sign. L is silent. So what is this Hermitage sign? Hermitage sign refers to shock-like sensation on neck flexion. Shock-like sensation on neck flexion, sudden neck flexion. Second, Euthoff's phenomenon. What it refers to? Euthoff's phenomenon refers to heat worsens symptoms or heat sensitivity of the symptoms. Third, Pulfrich phenomenon, where all two-dimensional events are perceived as three-dimensional. 2D to 3D perception is what we call as Pulfrich phenomenon. Okay. Now the next important area of MCQs for us is differentiating multiple sclerosis from other demyelinating disorders of CNS. So multiple sclerosis is one, the other one is neuromyelitis optica, the other one is myelin oligodendrocyte glycoprotein disorder or MOGD. All of these are demyelinating disorders of CNS. So what points will help us to differentiate between these? The points that are going to help us differentiate between these are which antibody, and then what structures are most commonly affected. So the antibody that is responsible for multiple sclerosis, we call it as anti-myelin basic protein antibody. Antibody responsible for neuromyelitis optica, which is also known as Devick's disease. Devick's disease. We have anti-aquaporin 4 antibody. Anti-aquaporin 4 antibody. And in the MOG disorder, we have anti-myelin oligodendrocyte glycoprotein antibody. It is there in the name. Don't bother about it. MOG. Okay. Then here, optic nerve involvement that we get. In multiple sclerosis, it is going to be unilateral. But in neuromyelitis optica, it is bilateral. In MOG disorder also, it is bilateral. Okay, so unilateral is only in multiple sclerosis. And in multiple sclerosis, it is affecting anterior part of this optic nerve. In neuromyelitis optica, it is affecting posterior part of the optic nerve. In MOG also, it is affecting anterior part of the optic nerve. So this combination, it's very easy. These two are anterior, but this is unilateral, this is bilateral, no confusion. Okay, these two are bilateral, but this is posterior, this is anterior, no confusion. So this permutation and combination is very rigid. Unilateral anterior optic neuritis is multiple sclerosis. Bilateral posterior optic neuritis is neuromyelitis optica. Bilateral anterior optic neuritis is MOG disorder. Then comes the spinal cord involvement. Because spinal cord involvement in the form of sensory tracts and optic nerve involvement are the most common manifestation, right? So spinal cord involvement in case of multiple sclerosis affects less than 3 segments. But in case of neuromyelitis optica, it affects more than 3 segments. In MOG, it is usually variable. Most commonly, this is also less than 3 segments. So MOG is usually not considered as a major differential in the exam. So this is where the questions come from, right? And that is pretty simple. Less than 3 segments is multiple sclerosis. More than 3 segments is neuromyelitis optica, right? It's there in the name. Neuromyelitis. Myel means spinal cord. Spinal cord is affected. Optica, optic nerve is affected. Okay. Now the last bit of point that you need to know is in terms of prognosis. This anti-MOG carries good prognosis. Why does it carry good prognosis? Because it is a monophasic illness. Means what? Demyelination happens only once. Multiple sclerosis, name itself says multiple, recurrence. Neuromyelitis optica, recurrence. MOG, recurrence is rare. Recurrence is rare. Okay, then this neuromyelitis optica, we say it carries poor prognosis. Why? First, recurrence. Second, it behaves like the primary progressive variant, means every time there is a demyelination there is no recovery, so it keeps adding to the disability. So their recurrence is very common, and recovery rare, something similar to the primary progressive variant. That's why it carries poor prognosis. Now, multiple sclerosis, I will count it as moderate prognosis. Why moderate? Because the most common variant of multiple sclerosis is recurrent, relapsing and remitting, where recurrence is common, but every time there is recovery happening. Primary progressive and secondary progressive are less common. So most patients do well. That's why we would count it as moderate prognosis, right? This is another important table that I want you to literally by heart, and I'm expecting one question this time on this. Okay. So that completes our multiple sclerosis as well. Now let's go to the stroke. So the next topic we are discussing is stroke. So we already know what is the definition of stroke. Stroke refers to focal or global neurological dysfunction of vascular origin. And that's why whenever we talk about stroke, focal or global neurological dysfunction of vascular origin lasting for 24 hours or until the death of the patients. And these strokes, because they are vascular origin, there are two things possible. Either there is ischemic stroke or there is bleed or hemorrhagic stroke. And when it comes to the hemorrhagic stroke, in the hemorrhagic stroke we have two categories. One of them is intraparenchymal, means inside the tissue of the brain, intraparenchymal bleed, and the second one is subarachnoid hemorrhage, because both of them can happen because of vascular pathologies, but the epidural and subdural are because of trauma, so they are not considered as stroke. For the intraparenchymal bleed, the most common cause is hypertension, and the most common site for hypertensive bleed is basal ganglia. And to be more precise, in that basal ganglia so many nuclei are there. The most common nuclei where bleeding happens is putamen. And the most common cause for subarachnoid bleed is going to be rupture of berry aneurysms. Trauma can also cause, but the most common cause is rupture of berry aneurysms. Now in your workbook, there is an ICH score mentioned for the hemorrhagic stroke cases. Please go through that, because they may ask a question asking you which of the following is the component of ICH score or which of the following is not a component of ICH score. What are the components of ICH score? The hematoma volume, whether it is less than 30 ml or more than 30 ml. GCS, age of the patient, less than 80, more than 80. Then whether there is infratentorial bleed or supratentorial bleed, whether there is intraventricular extension of the bleed or no. These are the points. Okay. Now when it comes to ischemic stroke, we will further classify them into thrombotic and thromboembolic. So overall 85% of strokes are going to be ischemic, 15% are going to be hemorrhagic. Out of that 85%, 50% are going to be thrombotic and around 35% are going to be thromboembolic. And when it comes to thromboembolic, what are the risk factors for thromboembolic stroke? The most common risk factor for thromboembolic stroke is atrial fibrillation, because atrial fibrillation causes stasis, and stasis increases the risk of clot formation and thus embolism. The risk factors for thrombotic stroke are all related to lifestyle. So what are the risk factors for thrombotic stroke? Atherosclerosis, right? A plaque forms, endothelium gets ruptured, platelets come, form a clot. That's how the stroke happens. So anything that increases the risk of atherosclerosis is a risk factor for stroke. And within that, you have to remember the most common risk factor is going to be hypertension. Strongest risk factor is what? Diabetes mellitus. That is the strongest risk factor. Apart from that, age, gender, all other, smoking, all the logical things that you can answer. Okay. Now, in medicine, I think I've already told you, we will be concentrating on ischemic stroke. Hemorrhagic stroke is pretty simple. Do the ICH score. If the prognosis seems to be bad, hand over the case to a neurosurgeon. He will decide whether he should do a craniotomy, burr surgery, or anything. It is a surgeon's fate. But ischemic stroke is a physician's fate, right? So let us see how are we going to manage a case of ischemic stroke. So when it comes to ischemic stroke, or for that matter, stroke, early recognition is important. So how do you recognize stroke early? So there are two things that help early recognition of stroke. One for layman and one for the clinician. And what is used for layman? For layman, to recognize stroke early, we have a protocol which is called as B fast, right? In the exam, they may ask what are the components of B fast. B stands for balance issues, E for eyesight issues, F for facial asymmetry, A for arm weakness, S for speech abnormality, T for time. So if patient family notices any of these abnormalities, without wasting time, patient should be brought to the hospital. And for a clinician, what is the protocol, or what is the point that helps you to quickly recognize stroke? We call it as pronator drift sign or Barry sign. Pronator drift sign, which is also called as Barry sign, where we ask the patient to hold their arms upright in supine position. Whichever side there is pyramidal tract weakness, that side starts pronating and drifting downwards, right? That can be an image based question. The image is there in the workbook. You can go through that. These are for the early recognition. Okay, once the stroke is recognized, how are we going to manage? So for that, we need to know how are we going to investigate, because once stroke is recognized, we don't know whether it is ischemic or hemorrhagic, right? So for that, I have to go through a diagnostic protocol. What is it? If you have a case of suspected stroke, the first thing you should do is you have to go for the non-contrast CT. CT is highly sensitive for identifying bleed. It never misses. So if it shows bleed, if bleed is present, it is hemorrhagic stroke. Do the ICH score, and if the ICH score is high, give the case to the neurosurgeon. And if the bleed is not there, then we will count it as ischemic stroke. Then it is ischemic stroke. And in all ischemic stroke patients, you might have to go for, if needed, you might have to go for CT angio to identify which blood vessel is blocked. It's not always required, but if needed, you can go ahead with that. In what circumstances it is needed, we will look at that later. Okay. So once you have diagnosed that this is ischemic stroke, now we will look at the management of ischemic stroke. How am I going to manage ischemic stroke? So when it comes to management of ischemic stroke, the ER management, what all we need to do in the emergency room. First thing is airway, breathing and circulation. Second, we have to check the GCS. And remember, when you check the GCS, if GCS is less than 8, we have to intubate. Why are we intubating the patient? To prevent aspiration. Low GCS means they have inability to swallow the secretions or spit it out, so they can aspirate, develop aspiration pneumonia. To prevent that, we have to intubate. Then third thing is we have to take a call about the BP management. And this is where in the offline classes, a lot of the students were confused. So let me clarify that one more time. Normally our blood vessels are capable of tolerating the blood pressure up to 220 by 130. Our blood vessels, normal healthy individuals' blood vessels can tolerate a pressure of this much. They don't rupture. If a pressure is up to this much, more than this much, they rupture. Okay. And there is a risk of bleeding. That's why 220 plus 130 plus is not acceptable for anyone. Whether you have stroke or no stroke, it's not acceptable. But in patients with stroke, you might remember in the workbook, we had studied the pathophysiology of stroke. What is the pathophysiology of stroke? Whenever, ischemic stroke particularly, whenever there is loss of blood supply to a part of the brain because of a clot, not everything loses the blood supply simultaneously. Let us say we are looking at this one particular case of stroke, and here the superior division of the middle cerebral artery is occluded. Here is where the middle cerebral artery is there, and this middle cerebral artery has a superior division and has an inferior division. This superior division gives blood supply to two major structures. One of them is Broca's area, the other one is the motor area. This is motor area. When the blood flow drops to less than 18 ml because of a clot being developed here, if the blood flow drops to less than 18 ml per minute per 100 gram of brain tissue, the areas supplied by this blood vessel stop functioning. So if the blood flows drop to less than 18 ml, Broca's area as well as the motor area stop functioning, and patient will have Broca's aphasia and hemiplegia. But these areas are still not dead, they have just stopped functioning. But when the blood flow drops to less than 8 ml, the area becomes dead. So when I started blocking this blood vessel, not all the areas supplied by this will have a blood flow drop less than 8 ml in one go. Slowly the blood flow starts dropping. So let us presume that the motor area blood flow is less than 18 ml, but it is still more than 8 ml. But the Broca's area, the blood flow has dropped down to less than 8 ml. Then what happens? Motor area will not be able to work. So what symptom it will lead to? It will lead to hemiplegia. Broca's area also will not be able to work. This is dead. This is dead, and this will lead to Broca's aphasia. But this area which is having less than 18 ml is not dead. It is revivable. If I re-establish the blood flow, it will come back. This area we will call it as penumbra. But this area less than 8 ml, it is dead. That area we will call it as infarct. So what is recoverable? Penumbra is recoverable. Infarct is not recoverable. So when I treat, only penumbra areas start functioning again. Infarcted areas will not function. And you know what is keeping this penumbra alive? Body's physiological response. When a blood vessel gets clotted, body increases the blood pressure so that more blood reaches this area and keeps the blood flow sufficient enough for it to survive. So if I lower this BP, the blood flow to this area will also drop to less than 8 ml. This will also become infarcted. Now neither I can recover Broca's area nor motor area. So this increase in BP is a physiological response to decrease blood flow to some part of the brain, and it is protecting the brain. We should not lower it. But if it is more than 220, 130, it will rupture and bleed. So that's why only when it is more than 230, 130, we should treat, right? So to avoid confusions on questions, I will give you a protocol. I will give you a protocol. What is it? If it is an ischemic stroke patient, right? This does not apply to hemorrhagic stroke. Whatever surgery teachers tell you about hemorrhagic stroke, follow that. It applies only to ischemic stroke. If it is an ischemic stroke patient, first thing you should see is, are you going for thrombolysis or not? If you are not going for thrombolysis, then treat only if more than 220 by 130 millimeters of mercury. Till that time, this BP is saving the penumbra, don't touch it. But if you are going for thrombolysis, then the risk of bleeding comes at lower BP value. 220, 130 is in normal individuals who is not taking any thrombolytic drugs. But if I'm giving thrombolytic drugs, you may bleed at lower value. If that is the case, treat if more than 185 by 110 millimeters of mercury, right? So this protocol, you remember, you will be able to choose what we need to do for the BP. Okay. After that, we will talk about the drugs that we will administer. What are the drugs we are going to administer? We are going to administer DAPT plus statins. Plus statins. DAPT means dual antiplatelet. So you know aspirin plus clopidogrel. But aspirin and clopidogrel is used for 21 days only. And after that, you are following with the single antiplatelet therapy. Either aspirin or clopidogrel will be continued. And when it comes to statins, we are using generally atorvastatin 80 milligrams or its equivalent dose of other drugs. Okay. Then you have to also remember here these dual antiplatelets should not give it. Do not give if patient is planned for thrombolysis, because thrombolytic agents plus antiplatelets increase risk of bleeding. Planned for thrombolysis. If the patient is not planned for thrombolysis, you give. But if you're taking the patient for thrombolysis, don't give antiplatelets. Okay, simple. So this is what you need to remember. Thrombolysis, whether we are doing it or not, influences whether we will treat BP at 220, 130 or at 185, 110. At the same time, the thrombolysis, whether we are doing or not, also influences whether I will give antiplatelets or not. Okay, done. Now comes, this is all emergency room management. Now comes the definitive management. What is the definitive management of a case of ischemic stroke? Revascularization. Definitive management of ischemic stroke. We will call that as revascularization. Opening of the blocked blood vessel. Opening of blocked blood vessel. And that can be done by two mechanisms. One is mechanical thrombectomy, similar to angioplasty, or you can have another method where you are doing thrombolysis. You are giving drugs to dissolve the clot. You can either call it as thrombolysis or fibrinolysis. In terms of efficacy, mechanical thrombectomy is superior to thrombolysis. Thrombolysis is successful in less than 50% cases. In less than 50% cases. But unfortunately, mechanical thrombectomy is not possible in all ischemic strokes, right? Only feasible in large vessel occlusions. So when large blood vessel is blocked, then we can do mechanical thrombectomy. Small vessels, we cannot do it. So that's why the protocol becomes little complicated. So whenever we have a case of acute ischemic stroke, the time of presentation after the onset of stroke decides who should go for mechanical thrombectomy and who should go for thrombolysis, because thrombolysis can be done irrespective of the blood vessel involved. By default, currently the guidelines recommend going for thrombolysis if they present within 4.5 hours and according to the Harrison within 6 hours. If they present within 4.5 hours according to guidelines or according to the Harrison within 6 hours, then the first thing we do is we go for thrombolysis if there are no contraindication. If no contraindications. But remember, thrombolysis is successful in less than 50% cases. So it doesn't mean that if we give thrombolytic agent, the problem is solved. And those who present after 24 hours. Remember, the time taken for the penumbra, which is survivable tissue, to dead tissue infarct is usually 24 hours. So by the end of 24 hours, all the area supplied by the blocked blood vessel is infarct. So there is no point in treating these patients by thrombolysis or mechanical thrombectomy. We offer them only secondary prevention by giving them aspirin and statins. But someone who presents between 4.5 to 24 hours or 6 to 24 hours, depending on whether we are following the guidelines or Harrison. Presentation between 4.5 to 24 hours or 6 to 24 hours, depending on the sources. Here you have some amount of penumbra and some amount of infarct. The penumbra is still savable, but thrombolysis is risky after 4.5 hours, so we don't go for it. So then what option I have left with? I'm left with only mechanical thrombectomy. But is thrombectomy feasible? For that I need to know whether large vessel occlusion is there or small vessel occlusion is there. That's why in these patients we have to go for the CT angio. And if the CT angio says there is large vessel occlusion present, then we go for mechanical thrombectomy. But if CT shows there is no large vessel occlusion, either small vessel occlusion or no visible occlusion, then we don't have the choice of doing mechanical thrombectomy because it's not feasible practically. So we have to only offer them secondary prevention. Another point to note here is the thrombolysis patients, only 50% clots dissolve, remaining 50% don't. So that's why I still need to do CT angio. And if CT angio still shows a large vessel occlusion, I have to go for mechanical thrombectomy. Clear? Okay. So that's about the management of ischemic stroke. In some of your apps, there may be questions related to NIHSS score, okay, National Institute of Health stroke severity score, and aspects score. Okay, those are not required for an undergraduate student, because even in these patients, if there is a large vessel occlusion, we can still decide whether thrombectomy is going to give any value to the patient or not. So there are some scoring systems like NIHSS, National Institute of Health stroke severity scale, and the aspect scoring of the CT findings. And based on that, we can decide where it will give maximum benefit and where it will give minimal benefit. If it is minimal benefit, leave it short though. Maximum benefit, okay, go ahead and do mechanical thrombectomy, not required at an undergraduate level. Okay, so that's about our stroke management protocols, right? Important MCQ points are related to this protocol. I want you to by heart this. Second, how long you give antiplatelets. BP, this is where a lot of questions come, and always remember when you have to lower the BP in both the cases, like thrombolysis, you're taking up BP is more than 185, 110, or you're not taking for thrombolysis, but BP is more than 220, 130. In both those cases, you have to lower it quickly. The drugs to go for are injectables, not orals. Clear? Okay, that's about stroke. I will just take 5-6 minutes more and then we can take our quick break. So now we will talk a little bit about two neurodegenerative disorders and then we will close the neurology. So the first neurodegenerative disorders that we are going to talk about is going to be Alzheimer's disease. Alzheimer's disease. So what is Alzheimer's disease? It is the most common neurodegenerative disorder. It's the most common neurodegenerative disorder. Most common neurodegenerative